Thank you for inviting me to speak to you today. It's now 17 years since Elizabeth Teisberg and Michael Porter wrote their seminal book, Redefining Healthcare. Some will say that not much has changed during these 17 years, and some even question whether the proposals were useful. I would admit that I've been frustrated over the speed of change. We still have cost increases in healthcare faster than GDP growth. We have waste, enormous waste, where we overtreat and undertreat. We also have a significant people crisis in healthcare, where experienced colleagues burn out and even leave the profession. The skeptics to value-based healthcare, they argue that, if anything, we need more fee-for-service, particularly to compensate for the COVID-19 period. But I would argue that if we continue down the path we've been on, the pressure on providers will get worse. We'll have even tougher cost containment efforts that we're exposed to, and there'll be even more constraints into the choices physicians want to do to help their patients the best possible way. Ultimately, the thumbscrews that are applied to healthcare today will be turned harder and harder. So I disagree with the skeptics. I would argue that over the past decade, there has been an exponential increase in the examples of value-based healthcare being put in practice, implementation around the world, whether it's payment models or providers changing the way they work. And these are proofs of concept that are very convincing and inspiring. But they're not enough. In order for value-based healthcare to have its full potential, it needs to be the foundational principle for how we organize and manage our healthcare systems. And as all of you are aware, healthcare systems are maybe the most complex systems we have in our societies. And in addition, because of the enormous investments we make in innovation and research, they're highly dynamic and adaptive. And therefore, it's very hard to predict how the system will evolve and what will become important and not. And it's actually equally hard to find a golden bullet with which the system will dramatically improve. Instead, we need to think of healthcare systems as evolution or ecological systems, where the evolution is what takes it into a different direction. And therefore, we need to shape the context that influences behavior, so that the behaviors we think are needed in the future healthcare system become rational to all stakeholders. Now, there are four levers which are typically recognized as central in complex adaptive systems, such as healthcare. And one of them is to set very clear goals, which are the same for all stakeholders in the system. In healthcare, those goals, I think, should be uncontroversial to improve outcomes that matter to patients, and to do that within the resource constraint we have. The second lever for complex adaptive systems is the resources made available, or the incentives. We need to have payment models which motivate all stakeholders to improve value for patients. The third lever is access to data. We need to be able to learn from our experience, to be able to follow a patient through the pathway, to be able to exchange information with each other, and yet do it in a patient-safe way. And the fourth and final lever is policies or regulation. And here we need to make sure that the policymakers step up and craft healthcare reform agendas which are coherent and consistent, and, for instance, make sure that we define goals that are coherent across the system and that we measure outcomes that matter to patients ubiquitously. We need to make sure that it's easy to develop the right payment models that motivate the behaviors we're aspiring to, and to make it easy to have access to data. Now, this is a framework that we use when we discuss healthcare systems at large at the national level. But many of you are clinicians, practicing doctors, maybe the heads of a department, and you'll ask yourself, so what can I do? Where do I start? Now, so I'd like to take a step back and reflect on why I chose to go into medicine. I saw medicine as a path for my life where I had the unique opportunity to combine my interest in the humanities and my passion for life science. The humanities, the socioeconomic determinants of health, the importance of compassion and empathy, and of course the explosion of molecular biology, bioinformatics, etc. But in our healthcare system today, where we are paid by fee for service, we focus on activities. These two have moved apart. Instead of working together, they're separated. If you're not paid for empathy, you're not going to be empathetic enough. And this is one of the reasons why we have big people crisis in healthcare, is that these have moved apart. We've become too technical. Now, if we define the goal of the system to be outcomes that matter to patients, we have to be holistic. You won't deliver long-term outcomes that matter to patients as a surgeon if you only have technical skills, if you're not engaged in the post-operative rehabilitation, if your engagement and dialogue with the diagnostic team is not there. So through outcomes measurement, ubiquitous to the system, we will be more holistic, integrate the two sides of medicine with each other. But also, it will be rational for everybody that we should be doing prevention. We should be doing early intervention for patients. But we'll also generate data which will allow us to apply advanced analytics and scientific methodologies for our healthcare reforms. It will be possible for us to identify wasteful practices and stop using them, or identify better practice or even best practice. We will be able to analyze the variation in outcomes across a population and try to understand the reasons for it, so we can become more and more precise in our therapeutic interventions. We'll also be able to develop the tools to much faster develop guidelines that are up to date to help clinical decision making. Now, the beauty of this is that if you have asthma or anxiety disorder in Calcutta or Cape Town, Stockholm, or in New York, you have the same disease, the same diagnostic criteria. And ultimately, the ambition or aspiration of patients are going to be the same. And therefore, we can standardize the measurements. We can use the same measurements across a country for anxiety disorder, or even between countries, and look at the differences to try to understand why some have much better results, much better health than others do, and apply the scientific and advanced analytics to learn from our experience. Now, this is in fact already available. There are instruments to do this, which are in place for anybody to use. And in fact, 10 years ago, Michael Porter, myself, and Martin Ingvar from the Karolinska Institute, we started a not-for-profit, an independent organization to bring together clinical leaders and patients to decide and recommend what should we measure. To date, over 250 American experts and patients and over 1,000 leaders across the world with patients have done so. They've defined the standard measures for 45 medical conditions, representing 60% of the disease burden. They have all been published in peer-reviewed journals, so colleagues have scrutinized the approach and found it to be sound. And very recently, and actually as we speak, these are being digitized. So it will be easy, and is easy, to integrate into EMRs, the research software, with the software to support payment models. In my mind, this approach is as critical for the development and improvement of our healthcare systems as the telescope has been for astronomy or the microscope for microbiology. And yet, some argue that it's impossible to measure outcomes across healthcare systems because it would add so much to the administrative burden of clinical teams, and not the least doctors already pressurized. And I agree with that. I agree with the burden. But I would argue we should measure less tomorrow than we do today. We should stop measuring the many things that are not used for anything and make sure we measure what matters. And what matters is if we're able to deliver good outcomes for our patients. Honestly, my sense is, how hard can it be? And to illustrate that, I'd like to share with you, I think, an example which has inspired many. And as I've gone deep into it, it's inspired me enormously. And that takes us back to 1962 in September, Well, JFK put up a very audacious goal for the United States to put a man on the moon within 8 years. And as I read about this, I pulled out a quote, which I think could be a quote as much about improving healthcare. What he said was, and I will freely read it to you, we want to do this not because it's easy, but because it's hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one that we're willing to accept and unwilling to postpone. It took 7 years to put 3 men on the moon. My question to you is, how long is it going to take for us to understand, truly understand, whether we deliver high quality care to our patients or not? And I'd like to share finally, before I end, this statement, which is known by all of you. Where there's a will, there's a way. And my challenge to you is, do you want to? Thank you for your attention, and I hope you'll have a very inspiring and exciting meeting the rest of the day.